Okay, so what I wanted to do today was just an overview of basically some of the non-gynecologic and gynecologic causes of heavy periods, and then what we can do to help manage those. As Natalie mentioned, this will be recorded, so it'll be available on the website. It'll be a nice resource for you guys afterwards, or if you wanted to point someone in that direction, if they weren't able to make it tonight, that would be awesome. And then please feel free. Any question is a good question. I'm happy to answer anything. And if I don't know something, I'll look it up and get back to you. All right, so just a quick overview of my disclosures. I do have some relationships with different commercial companies, and I'm also on an advisory board for the Canadian MRKH Foundation. I have no potential conflicts of interest for tonight's discussion. So in terms of the objectives, so first what I wanted to do is actually define heavy periods, which is a bit of a basic thing, but it's actually a bit hard to conceptualize, whether someone actually has an issue with their periods, especially people who are used to bleeding more heavily than usual. They might think that what they're experiencing is kind of normal for them. So we're actually going to quantify what a heavy period is. And then we're going to review some causes of heavy periods. And again, some gynecologic, some non-gynecologic. And then we're going to focus on some management options. And what I'd like to do is kind of focus on the most appropriate options for patients with inherited bleeding disorders so that it's most relevant to those joining today. So what is a heavy period? So first of all, we can define it based on symptoms. So what someone is experiencing. So basically it could be defined as excessive menstrual blood loss where it's actually interfering with the person's life. So either physical, emotional, social, and material quality of life. So potentially impacting the ability to go to work, to go to school, enjoy activities, engage in a healthy sexual relationship. There's lots of potential impacts there. And so that is just a broad definition based on symptoms. Other definitions that we use are a little bit more concrete, and we actually look at volume. So a loss of greater than 80 mils, okay, of blood loss per menstrual cycle, which doesn't actually seem like a lot, but the average person or the average blood loss that we expect for a menstrual cycle or a period is actually only about like 30 mils. So it's not much. And we do have these menstrual cups now where people can actually measure the volume, but before we were using menstrual cups, and a lot of people menstrual cups don't want to use them or it doesn't work for them. We like to use something called a pictorial blood assessment chart. And I'm not sure if any of you guys have seen this or used this before, so I just wanted to go over what that was. And so this is the OG, the original PBAC, and this was brought to light in kind of the 1990s and was meant to try to quantify how much bleeding someone was actually experiencing. And so what they did was they asked people to keep a tally of the amount of menstrual towels or pads that they were using and tampons, and looking at how soaked each of those products were. And then looking at how soaked, you counted it up, you tallied the score for each one. And then they had a cutoff of the number of points per cycle that would define heavy bleeding. And for these PBAC charts, they actually would recommend a specific menstrual product brand so that they knew kind of typical absorbency and that sort of thing in order to make it comparable. But obviously there's so many different menstrual products available, so that's not usually used now. People kind of use what they use. However, there is a new kid on the block that's a little bit more recent that we're using a bit more often, that actually accounts for how much blood might actually be in the toilet as well, because that's something that we don't always capture when we're just looking at the type of menstrual products we're using, and also looking at blood clots. And again, so for each of the days of the cycle, you just tally how many of each you use, and then there's the score right beside, and then it's easy to kind of count those out and decide whether or not someone meets criteria for heavy menstrual bleeding. Okay. So more period problems that I wanted to mention, because it's not just heavy flow. There can be issues with whether or not someone has a regular cycle. There can be issues with frequency, so how often we're having a period, the duration of the period, and then other forms of non-menstrual bleeding. So I've highlighted the ones that might be more of an issue in someone with a bleeding disorder. The one of them here being just frequent bleeding. So someone who's having periods less than every 24 days. And that starts at the first day of one period to the next first day of the period. So within 24 days, they're having another cycle. Prolonged bleeding, so anything greater than 8 days would count as prolonged bleeding. And then there's other forms of period of bleeding outside of periods that can be a concern. So intermenstrual, so bleeding between normal periods, people call that like spotting or breakthrough bleeding, but it can be quite heavy in people who have bleeding disorders. Postcoital, so bleeding that happens after sex. And then also premenstrual, postmenstrual, so bleeding that might occur just before a cycle or just after, that kind of trails on longer. So that, you know, we hear sometimes people having a period that lasts 14 days, but it's like 9 days of heavy bleeding with a few days afterwards. And so all of those types of bleeding wouldn't kind of be normal in this case. So causes of heavy periods, we use a really simple classification system in gynecology, which is kind of nice. And I will go through some of these causes with you just to kind of give you a sense of what we're looking at when we're seeing someone with heavy periods. So this is the Palm-Cohen FIGO classification for heavy periods. And so we divide it into two major categories. What are some structural causes? And so these are structural causes inside the uterus. And then some non-structural causes. And you'll see here I've highlighted coagulopathy because that's where our bleeding disorders come into, okay? And just because someone has a bleeding disorder doesn't mean they don't have other potential causes. And that's where I come in as a gynecologist often to make sure, is this just bleeding because someone has a bleeding disorder? And then we manage that. Or as a gynecologist, is there anything else that we could actually be managing to improve things on top of addressing the bleeding disorder issue? All right, so we're gonna kind of go through these quickly. So I've included some pictures because I find it helps to kind of visualize what we're looking at in terms of structural causes. So the P in the Palm-Cohen stands for polyps. So polyps are like little skin tags or growths that are inside the uterine lining. And they kind of hang off like this. They have a thin stalk, and over 95% of them are completely benign. So non-cancerous, we don't worry about them other than the fact that they can actually cause quite significant bleeding, either during the period, but they're also really, really common to cause intermenstrual bleeding. So that bleeding in between periods, okay? These polyps can also be vascular, which just adds to the amount that they can cause bleeding. The A stands for adenomyosis. So adenomyosis, so this is a picture here of a normal uterus, and the lining of the uterus sits kind of all along here. These bubbles here are basically just showing that the lining of the uterus that usually grows and stays just inside the uterus actually starts growing inside the wall of the uterus. So this muscular wall that should be nice and uniform and smooth, it ends up getting some lining that grows there, and that can cause really heavy and crampy periods. The L stands for leiomyomas, fancy word for fibroids. And fibroids are smooth muscle balls that can grow in the uterus. And so these, again, like polyps, are usually completely benign, okay? But they can cause lots of problems. They can grow inside the uterus, so they can kind of be hanging on like a stalk. And these ones are the ones that get really, really bothersome for periods because they distort the lining of your uterus. And they make it really hard for you to stop bleeding after a period once that lining is shed. Other fibroids you can see could get really, really large, right? And that can cause like lots of pressure symptoms and maybe some pain and that sort of thing. But these ones, these inside ones, are definitely the ones that we worry about more for bleeding. Then the M, so this is the last one in the structural causes, basically includes malignancy, so cancer, and hyperplasia. Hyperplasia is thought to be a bit of like a precancerous condition in a way because it's an overgrowth of the lining of the uterus when it shouldn't be. However, there are some forms of hyperplasia that we're less worried about, ones that are simple. But the atypical hyperplasia, where there's starting to be some cells that look a bit funny, we do classify that as a precancerous condition and something that we have to keep a really close eye on, and usually we end up treating. And then M basically is referring to endometrial or uterine cancer. Okay, so now in terms of the non-structural causes, so the C is the coagulopathy group. And so within C, we actually look at two major groupings of people, those who have inherited bleeding disorders or those who have acquired bleeding disorders. And so the most common inherited bleeding disorders we're going to look at are hemophilia A, hemophilia B, and then definitely von Willebrand's disease. Those are kind of the three that we're seeing most often. The other one that's coming up a bit more now that we have better testing in terms of platelet aggregations is inherited platelet function disorder. And the hematologists do a lot of investigations for that within our clinic. And then in terms of acquired bleeding disorders, things like DIC or ITP are pretty rare conditions, but that can definitely cause some issues with heavy periods. So in terms of inherited bleeding disorders, there's a couple ways of looking at this. So we can look at kind of the proportion of patients who have inherited bleeding disorders and how many of those patients would have heavy periods. And it's quite often many. The range, they say anywhere from 57 to 93%, but I would say it's definitely closer to that 93%, compared to about 10% in women without a known or identified bleeding disorder. Okay. And then the flip side is when we're looking at patients that are initially presenting with a heavy period and we investigate them for a possible bleeding disorder, about 10 to 20% of those patients are found to have a definable bleeding disorder. Okay. And especially in teenagers. So when I'm seeing a teenager who presents to the hospital with their first period and they're now anemic, so they've now dropped their hemoglobin half points, let's say, the risk of that person having a bleeding disorder is extremely high. Okay, it's upwards of about 50%. Okay, so definitely heavy bleeding requiring transfusion or requiring admission to hospital or presentation to hospital, really have to think about a bleeding disorder in that case. And in terms of the most common bleeding disorder we see, definitely von Willebrand's would be about 70% of cases. So by far the most common we see, but not the only, obviously. So the O is for ovulatory dysfunction. And I like to show this picture just because it shows a little bit of how the menstrual cycle works. So early in your menstrual cycle, your lining of the uterus is building, preparing for a potential pregnancy, right? That's what the cycle is all about, reproduction. We end up releasing an egg midway through our cycle. And then if there's no pregnancy, this lining builds, and then it decides to start shedding, okay? Obviously, if there is a pregnancy, this lining doesn't shed, okay? So what happens in ovulatory dysfunction, some patients don't always release an egg every month. This is super common when teenagers are first starting their periods. So in their first 1 to 2 years after having their first period, we often don't release eggs, okay? And that's just the body trying to sort itself out. That connection between the brain, the ovaries, and the uterus still needs to kind of get flushed out. And so often we end up with these non-ovulatory or non-egg releasing cycles, and the line just gets thicker and thicker and thicker because it doesn't know to shed. And then what we end up is a super thick lining that just sheds whenever it wants to because it got too thick. Okay, so that tends to be a bit of an issue, can definitely be an issue in adolescence, can also be an issue in patients who have polycystic ovarian syndrome because they don't always release an egg. So PCOS, you might have heard of that. That's a common condition where this occurs as well. So E, endometrial, I would say most people don't actually end up ever falling into this category. It's pretty rare, but if someone has like a chronic inflammation or infection of the lining of the uterus, that's a possibility. And then I, iatrogenic, basically means we're doing something to cause the bleeding. And one of the groups of patients that I see a lot in the women and bleeding disorders clinic are actually patients who've had blood clots before, and they're placed on blood thinners, right, to help treat their blood clots and prevent blood clots from happening. And then they bleed like someone with a bleeding disorder because they're on these medications to thin their blood, right? So that's kind of one of the more common culprits. And then there's other medications that can cause weird bleeding as well. Definitely all of the medications we use for hormonal regulation and birth control and that sort of thing can all cause weird bleeding as well. It's always a side effect. And so important for us to look at what medication someone is on when we're looking at the types of bleeding they're having. And then N, not yet specified. Again, we're not often using this category. It's pretty rare. Uterine arteriovenous malformations are quite rare, but they can cause pretty catastrophic bleeding in the event that it happens. So hashtag not an ad, but I can't say enough good things about having patients enrolled in combined clinics with gynecology and hematology. We see patients even like before they start menstruating, our pediatric patients who we know are going to start menstruating at some point, just to kind of prepare them for the possibility of heavy bleeding. And then we have a pediatric hematologist and an adult hematologist. So I end up seeing the lifespan patients for the gynecologic issues, but we work very closely with the hematologist in order to kind of address everything all at once. So it's kind of one-stop shopping. And then neither specialty kind of forgets about the importance of the other, because again, we know there's a lot we can say is due to a bleeding disorder, but we can't just say that it's due to a bleeding disorder if we haven't ruled out anything else. And then we have lots of tools as gynecologists to help treat these problems. So, all right, so whenever someone kind of comes to me initially or comes to our combined clinic, as a gynecologist, I want to find out why we're having heavy periods. And again, just because someone has a bleeding disorder, yes, for sure, it's going to contribute to heavy periods, but it might not be the only cause. And that's why we always want to put our gynecologist hat on and make sure we're not missing anything. So always doing a careful history. So asking lots of questions about the periods and when they're happening and how they're happening and how often we're changing, and using things like the pictorial bleeding assessment charts in order to get a sense of how bad this problem really is and how much it's impacting someone's life. So we always start off with a really thorough history. And then on a physical exam, always looking for someone's vital signs. So maybe signs that they're actually already anemic by the time they're seeing you. Is their heart rate really fast? Is their blood pressure kind of low? Always looking at things like the thyroid, because the thyroid can actually be another cause for ovulatory dysfunction, one of those non-structural causes. And then we look at the skin and look for signs of, platelet function issues like petechiae or bruising. And then an abdominal exam just to feel for any masses. So as gynecologists, we always like to do that, feeling for any fibroids, let's say. All right. And then in terms of the gynecologic exam, so I would say that this isn't always necessary, especially when I'm seeing a pediatric or an adolescent patient. A lot of this is not going to be necessary, but in some patients it is indicated. So doing examination to actually look at the vagina, look at the cervix, feeling the uterus and feeling the ovaries and making sure that everything feels normal. And then sometimes there's some testing that might be appropriate. So if there's, bleeding after sex and we're worried about maybe an infection, or a cervical change, we can do pap smear cultures. And then for the structural cause, the M cause, so malignancy or cancer, sometimes we actually do an endometrial biopsy, which means sampling the lining of the uterus. That's in patients who are, more concerned about cancer. And so those patients would be women over the age of 40, those who are overweight or have a BMI of greater than 30, those with polycystic ovarian syndrome, or those who've never had babies before and they're at an older age. Any of those kind of patients might meet criteria for just sampling of the lining to make sure we're not missing, a more serious issue. And then in terms of workup, so often we're ordering blood work with our hematology friends to make sure that there's nothing that they want that's special. And they often do lots of coagulation profiles and factor deficiency tests and platelet ags and all that stuff. But for me as a gynecologist, I really like the complete blood count and an iron level. And then I never forget to test their thyroid, because again, that's one of the more common causes of having ovulation problems. And then we can do some imaging. So again, not super common that I need imaging in a teenager, because I think the risk of things like structural causes are much more of an issue the older we get. But definitely if there's an adult that's presenting, I usually like to just get a baseline picture just to make sure there's none of those structural causes there. Okay. So now we're going to switch gears and we're going to talk about how to help with these periods. So there is a huge list, which is awesome because it means that we have tons of choices on how to manage periods. You can see here most of the chart, 75% of the chart here is all looking at medical therapies, which is great. And then the last part of the chart is looking at some surgical options. And we'll talk about those. And the nice thing within the medical options is that we actually have some hormonal options, but also some non-hormonal options, especially for those who are a bit wary of being on hormonal medications and wanting the least kind of invasive, the most natural approach. We do have some non-hormonal options, and so we'll talk about those as well. So one of the things I will say before going deep into the different options we have is that we really want to direct our treatment to the cause. So if I know that the main cause is a fibroid, well, I'm going to want to address the fibroid, right? Or if I know that there's really no other cause other than the bleeding disorder, then we address the bleeding disorder, right? And sometimes the management options or the treatment options are the same regardless. But if we do know a cause, we like to kind of target it as much as possible. So once we've ruled out cancer in patients who would be potentially worried about cancer, because I'm not worried in every patient, and we've ruled out significant pelvic pathology, so that's the structural causes, medical treatment, so non-surgical treatment, is definitely the first choice, okay? And that can be non-hormonal or hormonal. In patients who also want effective birth control, hormonal options are an amazing option because they provide both, right? So it's kind of two birds, one stone. And so we often offer that. That being said, hormonal therapies are an excellent choice, even if someone is not requiring birth control. So I often have parents ask me, well, my daughter's 13 or 14 and she has heavy periods, but I don't think she needs to be on birth control. She doesn't want to be on birth control. And that's why I kind of normalize these medications as kind of my period pills or my period medications, because I have so many patients on these medications that are not using them for birth control. And we kind of have to remove that kind of stigmatizing word, because not everyone likes the idea of being on a birth control product when they're not sexually active or not prepared to be sexually active. All right, so if we look at the hierarchy, right, in terms of what are the most effective treatments overall, we have this nice little chart here. And the percent MBL reduction is like major blood loss or menstrual blood loss reduction. And so removing someone's uterus, well, they're not going to bleed anymore, right? That's 100%. But that's like really, really invasive. And that's kind of the last line. And so most people coming to me aren't asking for this. Not true all the time. Some people do come in asking for a hysterectomy, but often they're looking for other options before then. And so we can kind of look at some of these options that are really, really effective medical treatment options that aren't, going to this 100% hysterectomy. And one of the things that's really, really nice is that we have medical options like this IUD here, the LNG IUS, which I'll talk about, that can be almost just as effective as a hysterectomy. So since we started having this product on the market, our rates of hysterectomies are going down, and we're really saving a lot of uteruses, which is great. We have other procedures like the endometrial ablation, which I'll talk about, which are more minimally invasive and don't involve, a long recovery. And then we have lots of medications, and we'll go over some of those that are most relevant. Okay, so non-hormonal treatments. The first thing I wanted to chat about is tranexamic acid. And it's possible that you guys have already heard about this medication before, because it's pretty common that people are prescribed tranexamic acid before they even get to me as a gynecologist, because they use it for nosebleeds, or they use it for upcoming procedures like dental work or surgery. And so they're already used to this medication. So tranexamic acid is an antifibrinolytic. What it does is it reduces clot breakdown. So it actually stabilizes clots. It doesn't form clots, but it keeps them nice and stable so that we don't have that continuous flow of bleeding. And it actually decreases the blood loss by about 50%. So you can see here from that chart, fits around here, kind of midway down, anywhere from 40 to 59%, but practically speaking, I would say it's about a 50% reduction in blood loss. We have two ways to give it, and the most common way that people would be using it from home is an oral medication. So usually we start at 1 gram, so that's 2 tablets every 8 hours or 3 times a day, and they're quite large. So for anyone who's taken them before, they're kind of like horse pills a little bit. They're quite large. And so not always the most beneficial in someone who, like, let's say, doesn't know how to swallow pills. So our younger patients, but definitely people who are used to swallowing pills, multivitamins, it's about the same size. And that can be a really effective option that you use just during the period. You can actually increase it to up to 4 times per day very safely. And then there is an IV formulation. So let's say people who are having surgery, we often give this medication IV. Let's say someone's coming into the emerge because they've had such a heavy period that they're just not coping at home and they're feeling unwell. We can give it through the IV and it works very quickly. Most common side effects that we hear is just a bit of nausea and some headache. I would say the number one reason why I've had people tell me they can't take the medication is because of headache. But I have lots of patients on this medication who don't struggle with headache. And so it's usually one that's very, very well tolerated. And again, the nice thing is you're just using it during the period. So it's kind of a nice little band-aid during that period, especially for someone who doesn't want to be on medications kind of all the time. Reasons why someone can't be on the medication, so contraindications, if they have an active blood clot in their legs or their lungs, because again, this medication reduces clot breakdown. And if someone has a clot in the legs and their lungs, we want that clot to break down. We don't want it to sit there forever, right? So someone with a clot, this medication is not for them. Anyone who's had a stroke, again, same kind of principle. They're more at risk of clot, and so we don't want to give them this medication. And then actually color blindness, just a random trivia thing, but for some reason, people who are colorblind, that can get worse with the medication. And I've also had some people who didn't know they were colorblind, and then we put them on the medication. They're like, their color vision's all off. And then we realized, oh, they might actually have color blindness. So more of a trivia for me than anything, but we always check. All right. And then, so usually we treat for 5 to 7 days. I usually say 5 because even if someone is having like longer periods before starting the medication, once you start the medication on the first day of bleeding, once you start bleeding, you usually only need about 5 days in order to stem that flow. And so, but you can use it a little bit longer if you need to, but typically about a maximum of 7 days. So desmopressin, I will be the first to admit that I don't know a whole lot about desmopressin. That's what our hematologists are for sure. But known as DDAVP or Octostim. Unfortunately, I know that we've been having a lot of trouble getting the intranasal spray for our patients. I don't know if it's just not available anymore, but a lot of our patients now are just using the sub-Q option, which is just an injection right under the skin. But there's also intravenous or IV formulations, again, in the event of an emergency or for pre-op. And so the way this medication works is that it helps release von Willebrand factor from storage sites within the body. We increase our levels of these factors, and then we get a reduction in blood loss. So it can be very helpful in more mild forms of von Willebrand's disease, like the type 1 patients, mild hemophilia A, and then mild platelet function disorder. So sometimes we have patients who are using desmopressin during their periods or just in the event of any major procedures. Some of the side effects, so there's facial flushing, headache, nausea, and sometimes some abdominal cramping. And then really, really important to limit fluid intake during that time because of the effects on water reabsorption with this medication. And the hematologists usually go over all of that with patients. And usually we say treat for about 1 to 3 days. And so if someone's having really heavy prolonged periods, this might not be the main option for them, but could be a nice additional option to kind of help the other methods work better. And so that's an option. In the chart, whenever gynecologists talk about heavy bleeding, we always say that non-steroidal anti-inflammatories, so like medications like ibuprofen and naproxen, can be used to help with heavy bleeding, but not in patients with bleeding disorder. So the majority of the time, you're going to have either like an allergy or like a warning, don't use these medications, not safe for you. And so unless your hematologist has kind of said, these are okay, we're probably not going to use them. There is one exception. Celebrex works a little bit differently than the other medications. And so sometimes we use them because they don't cause as many effects on the platelets themselves. But I would need like definitely some guidance from hematology to say like, yes, in this particular person, we can use it. And there's so many other medication options that I don't really feel strongly about using these medications at all. And they're definitely not the most effective by any means. So I usually don't spend too much time talking about this. Iron. I can't talk about heavy periods without throwing out an ad for iron. It is mandatory in patients who are having either low blood count or iron deficiency from heavy periods. So if we are now treating the heavy periods and we've gotten excellent control and iron stores are better, great. But if we're still in that phase where we're not really under control yet, or we're just starting treatment, we haven't started treatment yet, at baseline, iron is kind of the what you need to keep your stores up and just keep you feeling better. And there's oral and IV formulations. Oral, definitely some side effects associated with it, some GI upset, constipation, that sort of thing. So for people who either don't respond well to oral iron or just don't tolerate it, there's lots of IV formulations, and our hematologists often organize that for our patients as well. So hormonal treatments, this is definitely where as a gynecologist, I'm coming in with all of these options. And the first one I wanted to chat about was the levonorgestrel IUS, also known as the Mirena IUD. To note, there is another levonorgestrel containing IUD called the Kyleena, smaller, has a little bit less hormone in it. And usually for bleeding disorder patients, I do recommend the one with more hormone because I think more hormone, more effective, faster rates to having no periods. And so I usually go with this one. In terms of the way it works, so it sits inside the uterus. It can be placed either in clinic during a normal pelvic exam. For patients who've never had a pelvic exam before, who aren't comfortable having a pelvic exam in clinic, we can always do it in the OR with some light sedation. And so that's always an option as well. In terms of the benefits, so the biggest one is just a reduction here in menstrual flow, so in the amount of bleeding we're having. So about a reduction about 74 to 97%. And we have no periods in about 30 to 40% of patients. And this is like studies from the drug companies that are looking at like 0 spots of blood. So 30 to 40% have 0, nothing, which is fantastic. But closer to like 3/4, maybe 75, 80% have just very light bleeding every once in a while. That's quite manageable. It also helps with period pain, because the less we're bleeding, the less clots we're passing, usually the less amount of pain that we have. And then it's also, because it's a hormonal method, an effective form of long-acting reversible birth control. So this IUD is good for 5 years, which means that it can provide birth control for 5 years, but it can be pulled out at any time if someone wanted to get pregnant. And so it also has that added benefit. But again, doesn't need to be only used in someone who needs birth control. The management of the periods is reason enough for many patients. The one caveat I'll say about the timeline, so the 5 years, doesn't always pan out that way for someone who has a bleeding disorder, because we just tend to fail a little bit earlier. And so sometimes it's like the 3.5 to 4 year mark. I find that I'm changing it out for patients who have a bleeding disorder, just because they tend to kind of lose that suppression faster and they're more likely to bleed. So we kind of get it in a little bit sooner. Some people actually decided that just even before having any spotting, they want to change it out at the 4 year mark, because they've decided that that's what they're most comfortable with. And so we're happy doing that for those patients who want that. And so there have been studies looking at like an IUD versus surgery. And so with the hysterectomy, so removing the uterus, we remember from the chart, it's 100%. If the uterus is gone, it can't bleed, right? But there are some more minimally invasive procedures, like burning the lining of the uterus, so the endometrial ablation, which I will have a little slide on later, that is pretty equivalent to using the IUD. So we do find that it's often a toss-up for people between wanting an IUD or an ablation, especially when they're like done having kids or like older adults, when we're actually talking about ablations, because after an ablation, pregnancy isn't really an option at that stage. And so this is often kind of the decision-making point, and very, very similar effects at the 2 year mark for both of those. So the IUD is a good way to avoid surgery, but also the surgery is quite effective. So they're about the same in terms of efficacy on that chart there. So in terms of the IUD, so the risks, because we talked a lot about the benefits and I think they're great, but there are some risks associated with anything we do. Again, we put it inside the uterus. So anything that goes inside the uterus could potentially cause a problem. So the most common thing during the insertion is pain. And that's why we do have the opportunity to do this in the OR with some light sedation for those who really don't feel like they would be comfortable with a pelvic exam. There is a possibility that the IUD falls out. That's an expulsion. I would say that the risk is definitely higher for someone with a bleeding disorder. And so I do typically recommend for someone who has a bleeding disorder to use tranexamic acid starting the night before and to use it for the first 5 days after, in order to help reduce the fact that they could have a really big bleed and then the thing just falls out. Because, you know, it's a bit of an undertaking to get it placed. People are usually pretty anxious about it. And so if it falls out right away, that's not great. And then small risk of infection, because we're going from the vagina with not not the most sterile environment, to the uterus, which is completely sterile. But we clean off that area in order to decrease the risk. And it is less than 1%, so it's super rare. The IUD doesn't even need to come out if we have an infection. We just treat it with antibiotics, and then we go from there. Lastly, there is a very small risk of what we call a perforation during the insertion. So we put the IUD in. It's a blind procedure that we do by feel. And so if it goes into the uterus, there's this theoretical risk that either the instrument or the IUD could actually poke through the uterus, and that's called a perforation. Again, super rare, less than 1 in 1,000, even more rare that it's the IUD that actually perforates through. I would say the risk of perforation is definitely lower if you're going to someone who has lots of experience putting them in. And then lastly, if we are using this medication for birth control, there is a small risk of failure for birth control. It's about on average 1 in 1,000, anywhere 1 to 2 in 1,000. And if it were to fail in that way, there's a slightly higher chance that the pregnancy could be in the fallopian tube or an ectopic pregnancy, because there's something sitting inside the uterus trying to prevent pregnancy. So it kind of gets stuck, the egg and the sperm kind of get stuck together in the fallopian tube. And so if someone were to think they were pregnant with an IUD, then we get them to do a pregnancy test. And if it's positive, we do an ultrasound to find out where that pregnancy is. In terms of side effects, the most common thing is what we call nuisance bleeding. Nuisance because it's like super annoying, and it can last up to 6 months. But I would say, just in terms of experience, most of the time it finishes by 3 months. But it's a bit unpredictable. It could be heavy or light, and we just kind of have to hold on a little bit. Sometimes use tranexamic acid for the first little while in order to let that IUD settle and let the hormone in the IUD take effect. Very rarely, because the hormone in the IUD, the progesterone in it, it's that hormone that you get before a period. So it's that like bloated breast tenderness, sometimes some headaches. That hormone is really high when you first put it in, right? And then it slowly kind of absorbs into the system. So sometimes when we first put it in, we can get some effects in terms of that higher dose of progesterone, but it's very short-lived, if anything. And then reasons why we can't use an IUD. So if we think someone is pregnant, or we have a high suspicion that they're pregnant, definitely don't put anything inside the uterus, because that's going to harm the pregnancy. If they already have an infection in their uterus, we don't want to put something that can cause more infection. And then the other thing would be if the uterine shape is abnormal. So sometimes the uterus, it's supposed to kind of look like this, one cavity. Sometimes it's like 2 cavities, or there could be like a really large fibroid that's sitting in the uterus that's taking up all the space. That type of situation, we really can't put in an IUD safely, because the risk of it kind of falling out or getting stuck in the wall somewhere or perforating is actually a lot higher. So we wouldn't recommend it. The next major grouping of treatment options are combined hormonal contraceptives. So these are your pills, your patches, and your vaginal rings. So your traditional kind of birth control options, okay? And so we call them combined because they have 2 hormones in them, estrogen and a progesterone. So if you remember, the IUD just had progesterone. These combined hormonal contraceptives have estrogen and progesterone, both hormones that the ovaries normally produce. We just give them in higher levels so that we can stop the typical cycling of hormones and we can kind of take over the menstrual cycle. In terms of the benefits, so we do know that it will decrease the volume of bleeding, but maybe by about 20 to 50%. So if someone has like very heavy bleeding, 20 to 50% might not be enough of a reduction. And so we'll talk about how we can use the medications a little bit differently and actually skip periods altogether. That's when these medications become super, super helpful with bleeding disorder patients. Definitely, they can improve anemia and iron deficiency if we do reduce the amount of blood loss. And these medications actually increase your von Willebrand factor levels. And so that's also something that can be helpful. And then ovulation pain. So patients who do have bleeding disorders, when they release an egg, can bleed from that site because it's like a mini trauma, right? Even though the eggs are like microscopic, they cause a hole in the uterus, and that hole can bleed. And so someone who's more prone to bleeding, 100% will bleed more. And they can get more pain because that bleeding that occurs is super, super irritating to the lining of the pelvis. And so very common that we have more ovulation related pain when we have bleeding disorders. And so these medications actually stop ovulation. And so we get less pain. Other benefits, and this is kind of the most important thing, would be cycle regulation. So let's say someone has these long cycles where they're like bleeding for 10 days. By giving someone a defined amount of time off of hormones, we can actually shorten their periods, and we can also skip periods, right? So there's nothing to say that we can't take 2 packs in a row of pills, 3 packs in a row of pills. Sometimes we actually use it continuously, which means we don't take a break unless the body just finally says, I'm starting to bleed because my lining got thick. But that could be like 6 months down the road, 8 months down the road, and then we've skipped all of this monthly bleeding. Okay, so cycle regulation is pretty huge. And then there's other potential benefits, things like acne, hair growth, ovarian cysts, PMS symptoms, and those are all reasons why, you know, patients, even not with bleeding disorders, use these medications. So in terms of side effects, I always have to highlight, and I think we kind of touched on this earlier, the, you know, medication related causes of weird bleeding. Well, these types of medications, definitely whenever we start them, can unfortunately cause weird bleeding. And so the hormones have to act on the lining that's already there. And so sometimes we get this weird bleeding when we first start, and people get frustrated because it's, you know, you're on this treatment to help solve the problem, and then you're creating a new problem because maybe you didn't bleed before until just your period, and now you're bleeding not on your period. And so breakthrough bleeding is something that, you know, we often have to kind of work around, usually by being consistent with the medications, not missing any doses. We get this under control within the first 3 months, but it can sometimes be a side effect that sticks around, and then we have to think about other options. And then other side effects are related to the estrogen in these pills. So nausea, breast tenderness, headaches, and then something called chlasma or melasma, is that darkening pigmentation of the skin. Some patients get it when they're pregnant. And so it's that kind of darkening of the skin that can happen with these medications. And unfortunately, it's not super reversible. It tends to lighten over time, but that can be a permanent change. In terms of risks, so the one risk that I usually talk about when I'm counseling about birth control or the combined contraceptives is risk of blood clots in the legs or the lungs. So in patients who are not using these medications, about 3 to 5 in 10,000 will randomly have a blood clot. Young, healthy patients, okay? That risk doubles in someone who's on one of these medications. So it definitely sounds really scary, a doubling, but it's still very, very rare. And in pregnancy, the risk is actually significantly higher. So it's about 10 times higher. And so for someone who, let's say, is having sex and does need birth control, then what you would say is, well, the risk of actually having a blood clot if you got pregnant would be far outweighing the risk of you being on the medication. And so that's kind of one way to I guess, justify it, or to make the risk seem not as great. And then we always talk about the potential signs and symptoms of blood clots and when to seek out medical attention. Anecdotally, in someone who has an inherited bleeding disorder, blood is thinner, less likely to clot. I would say that the risk of these issues are going to be more rare. It's definitely hard to study this, right? Because you have to have enough patients with bleeding disorders and then enough patients with clots, and clots are pretty rare. Bleeding disorders not so rare, but having them happen together with a birth control pill is pretty rare. So there's not a whole lot that I've come by looking at the association. But definitely our hematology friends kind of agree that this would be a pretty rare phenomenon. Reasons why you couldn't be on a combined contraceptive, so the pill, the patch, or the vaginal ring. If you're a smoker over the age of 35, if you have poorly controlled high blood pressure, severe liver disease, an active clot already in the legs or the lungs, stroke or heart disease. And then there's some other conditions like breast cancer and special migraines that have some neurologic changes. And the reasons for basically these contraindications are that they can increase the risk of stroke and also blood clots in the legs or the lungs. Okay, so often people have a question about tranexamic acid and combined hormonal contraceptives. And what I will say is, bottom line, short-term exposure to tranexamic acid, even while on a combined contraceptive, which can increase the blood clot risk, is going to be, the benefits are going to outweigh the potential risks. If someone, however, has increased risk for blood clots, so maybe they're wheelchair bound and they're not walking around, they have obesity, or they have a known clotting disorder, you definitely want to avoid the combination. But it is safe to use in the short term for someone who wants to stay on their combined contraceptive. Usually, the way we use it is we use the tranexamic acid while someone's having their break from, let's say, the pill, the patch, or the ring, right? Because then that hormone's out of their system while they're on their break, and they're going to have their period, and we use the tranexamic acid during that time. But sometimes people want to stay on these medications because as long as they can, or we're managing breakthrough bleeding, and we can use tranexamic acid on top of that safely for short periods of time. Okay. It's not something that pharmacists are always super comfortable with, so we do a lot of counseling about that. Their thought is that combined contraceptives can increase the risk of clot. Tranexamic acid stabilizes clot, but what we do know is that tranexamic acid doesn't cause clots, and so being on tranexamic acid won't increase that risk. And so there have been several studies kind of looking at that and comparing being off or on, and it seems to be kind of accepted that we can use it for short periods of time. So again, typical regimen, we use it while someone's on their sugar pills or they're off their patch or their ring, but we can use it for heavy breakthrough bleeding, for that nuisance bleeding, or if someone's using it in a continuous fashion for long periods of time, they really don't want to have a period, we can use it in that setting as well. Usually I would say for a maximum of 5 to 7 days. If someone is bleeding outside of that period and the tranexamic acid is not helping, we want to reassess what we're doing. I know I'm talking about a lot of different things. I promise we're almost at the end. Some people have questions about the shot or depot-medroxyprogesterone acetate. The shot is the typical birth control shot that you get every 12 weeks. The one thing I would say is it's an IM injection, so intramuscular injection. So someone with a bleeding disorder, we have to apply pressure for a long time. So for 15 minutes at minimum, in order to decrease the risk of bleeding within the muscle. And depending on the severity of the bleeding disorder, some hematologists will actually say like, no, this person shouldn't have an IM injection, especially when there's other options that don't involve potential trauma. It is a high dose progesterone only medication. Again, so that hormone that's in the IUD, this is like a systemic, so going straight to the bloodstream medication from the muscle. And typically people don't have periods with this medication. So we think, oh my God, it's fantastic, right? 60 to 64% won't have any periods. The downside is that about a third can have ongoing bleeding, and it often takes maybe 1 or 2 shots. So like by 6 months, we're getting there. And what I do worry about in patients with bleeding disorders is those 6 months just won't be feasible. Like it'll be too much bleeding because we can get very unpredictable bleeding even in patients who don't have bleeding disorders. And I just worry that much more in someone with a bleeding disorder. So It's not my typical go-to. I mention it because people often have questions about it, but I think that unpredictability in the first 6 months makes me steer away from this a little bit more and more towards the other options that are a bit more predictable and more under our control. Dynagest is a new pill on the block that is often used for endometriosis. It's a progesterone only medication. So remember that list of reasons why someone can't take a combined pill? Those are all related to the baddies and the estrogen. So when we look at Dynagest, it's a nice option for patients who can't be on estrogen for whatever reason. The smokers, those who've had a blood clot in their legs or their lungs, this medication is totally safe. It's not marketed as birth control in Canada. It's not really marketed as a period medication per se. It's actually marketed towards endometriosis, so a painful period condition. But one of the really nice benefits is that we have about 40% of patients who have 0 periods. So it could be a nice option for someone who does want a pill and who wants a daily pill, but who can't be on estrogen. The other thing is patients with bleeding disorders can also have endometriosis. And so this is actually a very effective treatment for endometriosis as well. And I think this is going to be the last medication that I talk about, GnRH agonists or gonadotropin releasing hormone analogs. These medications basically tell our brain to lower our levels of estrogen. So it kind of shuts off the ovaries and we end up with no periods. So super, super high rates with no periods. Okay, so we actually almost induce like a menopausal state. So that's where the side effects come in, because if we shut off the ovaries, we're going to get things like hot flashes, night sweats, vaginal dryness. The other thing we think about is bone loss. So patients who've had menopause, they're at high risk of osteoporosis. And so if we create menopause, we also increase the risk of osteoporosis. So this is usually a short-term option if someone is like awaiting surgery. It's not something that I put someone on for long periods of time. It is an IM injection, so that all of those precautions for IM injections still apply, but super, super effective if someone is having really, really uncontrolled bleeding. None of the other options are working and we're waiting for surgery. This is kind of my go-to. All right, so we're nearing the end, and then I'm sure you guys have lots of questions. So we'll talk about surgery just briefly. And so there's a couple main reasons why someone might want surgery. So A, if they're not actually responding to any of the medical therapy. So remember we said medical therapy, first choice. But if nothing's working and we've tried multiple options, well, maybe surgery is kind of the way to go. The other reason could be, what if none of the medical therapies are safe for that person? Maybe they've had lots of side effects. Maybe they can't be on estrogen and they've had a progesterone sensitivity. You know, I've definitely heard it all and I've seen it all. Definitely, you know, some people fall into this category where none of these options are really suitable. And so then we look at surgery. The other option would be if someone is significantly anemic. So we're not able to, you know, get them to bounce back with medical treatment, or they come in like actively bleeding and we have to do something quickly. That can be a rule for surgery. Sometimes it's a quality of life decision, someone not wanting to be on medications anymore, someone just wanting this to be dealt with definitively. And so that's an option. And then definitely those structural causes we talked about at the beginning. Surgeries are there to address those structural causes if we feel that we should use them. And so that's where we kind of direct some of these treatments to the underlying cause. So that's when surgery can be helpful. The different procedures, so the D&C, or the dilatation and curettage, that's that procedure where we remove the lining of the uterus. This is the one we can use sometimes in an emergency. So when someone comes in really, really heavily bleeding and it's from that thick lining and it's uncontrolled bleeding, well, we can actually remove that whole lining. And then without a lining there to shed, they're not going to bleed anymore. Okay, so this is someone presenting to emerge, lots of bleeding. we're needing to transfuse them, we need to stop the bleeding now or yesterday, we can do this procedure. Then we have the polypectomy, so removing a polyp, the myomectomy, removing a fibroid. So again, targeting it at that gynecologic structural cause. The endometrial ablation we mentioned, so burning the lining of the uterus, day procedure, short procedure. That's a possibility. And then hysterectomy, kind of end of the line option, but some people again choose this kind of earlier in their journey rather than later, and that's removing the uterus itself. Many options are available for minimally invasive procedures. So before, a hysterectomy meant a super large cut in the abdomen and a super long recovery period. Now we have a lot of these procedures that are day surgeries, even hysterectomies, and we can do it all with keyhole surgery or minimally invasive approaches like vaginal surgery. And so lots of different approaches and lots of different options for those who are actually considering surgery. Again, super important working with our hematology colleagues to make sure that someone is not anemic already at the time of their surgery, right? So unless it's that emergency person, but it does increase the risk of transfusion. And it also carries a risk of complications like infection, poor healing, if we're not already at a normal hemoglobin level. So we want to just make sure that we work with hematology to optimize patients' iron stores and their blood counts before surgery, during surgery, and post-op, just to make sure that we're giving them the best possible chance to have a successful surgery and a successful recovery. And again, not an ad, but I can't say enough about this combined effort between gynecologists and hematologists for our patients with bleeding disorders. It's really nice to have both lenses kind of focusing in at the same time and making sure that neither of us are forgetting the other person and that we're kind of coming up with treatment options together and with the patient, right, to find what fits best in line with what they want. And so I can't say enough about those clinics that do exist. And that's all I have to say. So I'm sorry if that was really long, but I hope that it was informative. And I welcome any questions.